So thank you. It's a pleasure to be here. My hometown, born and raised over in the northeast part of town by Lloyd Center and Grant High School, Irvington District. Happy to talk to you about scrambler therapy. I've been involved with it for a while. There's a couple of slides here for ACME credit designation and credit strategy statements. And this one too, a disclosure thing. My potential disclosures are that Competitive Technologies did provide a couple of scrambler machines and materials for us to do experiments at Mayo in looking at scrambler for the last 6 years or something like that. Recently they provided a small amount of grant funding by paper. I haven't actually received it yet. Another potential conflict of interest, and this allows me to come home to talk, so you could consider that a conflict of interest. So presentation outline here, I'll start off with conclusions. It's kind of late and people might want to be resting here at this time of night after a good dinner here. First thing is that there's no proof that scrambler therapy provides remarkable benefit. And I say this wearing my scientific hat. There have not been big randomized placebo-controlled clinical trials. And I'll go through the mechanism a bit more in a bit. So scrambler therapy history. This is kind of a fuzzy picture, but it probably fits best. It's actually even more fuzzy here. It's the best one I got on the internet. I had a picture of mine on the phone when I went over in Rome, but I couldn't find it. This is Giuseppe Marineo. He is the person who is responsible for developing this machine. He lives in Rome. He's not a physician. He is a scientist. Biophysical approaches to disease is what he's known for. He started off looking at ways of trying to take care of the problem of cirrhosis with biophysical things and electrical energy to try and get rid of some of the scarring in the liver, so therefore the liver would work a bit better. He then went from there into pain, and that's basically how scrambler therapy arose. Now let me go over a number of clinical therapy reports and trials that are out and about. I'll start off with our Mayo experience. We've been treating patients for about 4 or 5 years now. A little bit of the history. How did I get involved in this sort of thing? I first heard about it from Tom Smith, who's a medical oncologist who was at Virginia Commonwealth University at that time. He now is at Johns Hopkins, head of palliative care there, and a medical oncologist. And he first mentioned it to me because he had heard about this. It was developed for chronic pain, not chemotherapy neuropathy. I'm a medical oncologist, by the way, and what am I doing with other sorts of pains that I'm going to talk about? And we'll get a bit to there, but chemotherapy neuropathy. And so he had done a pilot trial that I'll show you about in a bit about this pilot trial. And he told me about it, and he told the company, Competitive Technologies, that there was marketing the machine at that time, that I do a number of symptom control trials, do a number of chemotherapy neuropathy sort of things, so they might want to talk to me. They did talk to me, offered me a machine, and I said, well, I don't know, I'm pretty busy with a bunch of things, and it sounds a bit crazy and that sort of thing. But I know Tom Smith well. He's a good oncologist, and I've known him for 15, 20 years. So I actually went out to Boston with a colleague of mine. We went on our own dime, a neuro-oncology colleague of mine. And we went out and we heard Giuseppe speak, and a couple of other few people speak. We actually talked to him one-on-one about it. My colleague kept on saying, well, how does this work? How does this work? How does it work? And I kind of said, well, that's kind of interesting and fun, but I'm more interested in does it work, does it work, does it work? Those are two separate questions, both important. I'd like to know the answers to both of them. But at any rate, I finally decided, all right, we'll take the machine and try it out, and went through Mayo processes and how we could accept the machine and all that stuff. And then we had somebody come out and did some training, and we were impressed by what we saw. We've treated over 200 patients so far. We've never charged a patient for it at this point in time. I think it belongs in clinical practice, and I'm working on getting that set up at Mayo. But right now it's been on research sort of process. I did along the way go and visit Rome after a couple of years of doing it. I said, we need to learn more about it. So I brought the team there, and that was very helpful in saying, oh, we need to think about this and that and put things down in writing. We visited Providence, Rhode Island, where there's a big practice out there also. So the clinical trial we have, scrambler therapy for the treatment of neuropathy and pain, an open access trial. This is not a placebo-controlled trial. It was developed to get experience, to figure out what we could need to do to get a placebo-controlled trial going. It required that patients had pain or CIPM symptoms. And the CIPM symptoms were either tingling or pain, not just numbness, but of greater than 1 month duration, with tingling or pain greater than 4 out of 10 during the prior week. The treatment is that we treated them with scrambler therapy to the affected areas for up to 10 30-minute sessions. Some patients, if they got pain, got better earlier, they could stop. If their pain all went away. Some patients didn't go through the whole 10 treatments, and we'll go over that in a bit. So initially, with what we did is we took our initial patient cohort, 37 patients who had chemotherapy-induced peripheral neuropathy. So most of you know that a lot of the chemotherapy drugs we can cause a lot of neuropathy. Oxaliplatin, paclitaxel is probably 80% of the problem because they cause a lot of neuropathy and they're used quite frequently. And then there are a variety of other drugs, cisplatin and carboplatin, not quite as much bortezomib, but and a few other drugs that cause this. So we took the first 37 patients who enrolled in the study, and some of these are our early patients there, and I'll show you in a bit that we improved over time. I think I'll be able to convince you of that. 25 had the most of the problem in their lower extremities. These are people who were all done with their chemotherapy. And 12 had the problem primarily in the upper extremities. During treatment with oxaliplatin, it's more of a problem in the upper extremities. Paclitaxel, it's always more of a problem in the lower extremities. But after you finish the treatment and you're following along, the lower extremities are the ones that are more problematic than the upper. This next slide actually shows you what I just showed you there. But we asked patients when they were done with their therapy, on a weekly basis, how much problem are you having with numbness, tingling, and pain? And we initially, when we started off, we actually did not ask that question during those 3 questions during the follow-up period. And so there's a fairly big drop off of patients here. And the reason, and what we did ask though, from day 1, is we asked a separate question, which turned out to be somewhat confusing, and asked them, how bad is your numbness, tingling, or pain? Take the worst of them, and how bad is it on a 0 to 10 scale? And that was somewhat difficult. Well, my pain was this, but my numbness was this, my tingling was this. So it caused some confusion, and that's why we decided to go to the individual questions later on. But what we saw with it is that it didn't seem like these patients did as well when they asked this particular question. And it might have been a bit more confusing, it should be a little bit higher, but it didn't stay down here. And we thought maybe it's some of the confusion, but the other thing we proposed is that maybe, because that included all of the patients, and we had a feeling that we got better as we went along. And so that might be because of that. So this shows you that exact same curve, looking at the numbness, tingling, or pain that I showed you in the previous slide. But we looked at in the patients that were early on, before we started asking those separate questions. And then the later cohort is in the yellow after we started asking those separate questions. And I think you can see that we did better with time when we asked in the last half of the study than we did in the first half of the study. And also the number of patients in the first half of the study, where we didn't do so well, we started off with 23 patients. We only had 7 patients who were there on the 10th day. And part of that is because we weren't as good at it, we weren't getting as much results, and kind of the patients might have been a bit discouraged by it. And also, we actually kind of said, well, it's not working after 3 or 4 days. Maybe it isn't worth you coming back. This is frustrating not only for you, but for us too. There's a little bit higher patients in follow-up because the follow-up could have been when you got done at day 5, we still did the follow-up thing. So that's why the number jumps from 7 to 12 here. But in this next group of patients, we start off with 14, and through 7 days we had 14, and we had 13 through 10 days. So we were more persistent, and/or we were better during that thing. And the drop-off here is not near so much, 12 out of the 14 that we started, as opposed to decreasing by 2/3 of the patient here. So the next thing I said, let's break our patients up into quartiles, our first 9, second 9, third 9, and fourth 9, but it actually had to be 10 because there were 37. And here are our first 9 patients, where we didn't see very good results. And then the second, third, and the last 9 or last 10 patients, we got better with time. So there is a learning curve with doing this process. We had been out to Rome, learned a bit through there, but they didn't treat chemotherapy neuropathy. We learned about low back pain and other things, but they didn't have a big oncologic population at that time. And what we learned mostly when you give these treatments, you go oftentimes on either side of the pain, ideally catching the same nerve in a couple different areas, but sometimes for back pain it's different nerves there, but on either side. But it's hard to get farther distant than the end of the fingers where the chemotherapy neuropathy is, or end of the toes. So what you do is you catch the nerves earlier, the same nerves that are causing the thing, and we catch them earlier and send that message to the brain. So then we have, this is the numerical information that we have on the 25 patients with lower extremities. And this is day 1 on through day 10. This is just the before treatment days. And in our data, when I showed day 10 of therapy, that was the before treatment information. Some of the studies up by others have used the after day 10, after day treatment. And with each treatment, obviously it gets better, but I think it's better to use it before my own class there. Back then. So looking at what other people have done, and I'm doing this kind of in a chronological stage after a couple of preliminary things to show which trials are out there. There are 15 trials or reports that I can describe here. 12 are published manuscripts. 2 are published abstracts, and 1 is our back pain study, which has not been published yet. 4 of the studies are, or 4 of the experiences are clinical practice experiences. They go back and looked at their patients that they had asked them, but they weren't really prospectively following them. 8 are prospective trials. 1 is a randomized controlled trial, open label, not placebo. And 2 are randomized placebo-controlled trials. The first trial, 2003, Giuseppe Marineo, and he's the inventor and that sort of thing, and so you can say this might be biased, he's got something to gain and all that sort of stuff. Patients with advanced abdominal pain from abdominal sort of cancers. He noted that pain was quickly and markedly reduced. 9 of the 11 patients stopped their pain medications within the first 5 applications. No side effects, he noted. Pain reductions continued until death. There were some patients who had recurrent pain and months later were successfully retreated. And these are the data that he demonstrated in his hands here with a pain score of about 8.5 out of 10 or 85 out of 100. Dropped down the first day here and dropped down quite nicely here. It's almost, this is unbelievable. We don't quite think this and that sort of thing, but that's what he first published there. Second trial, 226 patients with neuropathic pain. He's a second author in this particular trial. Prospective trial. The details are a bit sketchy as to whether it was IRB approved or not. It was done in Italy and it wasn't quite clear, or they just didn't say it in there, but noted that it would have failed back surgery or brachial plexus neuropathy or other things. 80% had greater than a 50% reduction in the pain. 10% had responded with pain relief between 25 and 49%. 10% did not have any response. And again, noted that there were no toxicities. Third trial, this is the first trial that was done without Giuseppe. This is Tom Smith, the trial that I talked about before that got me interested in this, looking at, when he heard about it, he said, let's try it for chemotherapy neuropathy. It's a big problem we see in practice. And so this is what he published that started off with a score of about 6 out of 10 and dropped down to about 3 out of 10, 2 or 3 out of 10. Now this was the last scores after the first day, which was before treatment. The other scores were at the after treatment for those days, which you might say is cheating a little bit, but anyway, that's what he has shown. Next trial out there is 10 patients. This is written by Dr. Abdi, who's an anesthesiology pain physician. Failed back pain surgery with a 28% mean pain reduction, which doesn't sound all that much, and maybe that's placebo effect. In talking to him, though, he said these are patients that everything else had failed. These were desperate sort of things, and he saw some wonderful sorts of responses. Sixth trial is another group of Italian authors, but not Giuseppe. He was not part of this. In fact, Giuseppe wrote afterwards a letter to the editor, said they didn't really treat it correctly. They should have done it this sort of thing. And Giuseppe is, as I said, an interesting person, but sometimes may not be able to describe things as well. I think it might be too bright in ways. You can't put it down in a simplistic sort of way to how you actually put this into practice for people who don't have the experience he does. But 73 patients. 50% had cancer, prospectively treated on a clinical trial. Pain scores reduced, 6.2 out of 10 before treatment, 1.6, 2.9 at this end of treatment, and 2.9 a month later. Similar with cancer versus non-cancer. And they asked the question, would you repeat this treatment? And 97%, or 71 out of 73 patients said yes, they would repeat this cancer. On our trials, we've actually asked the question, would you recommend this for somebody else? I actually have not analyzed those data. I need to go back and do it, but I think the answer is going to be 90 to 95% from what I recall from talking to patients. So the seventh trial, a series of cases of 39 patients with cancer pain syndromes, 33 of whom had chemotherapy-induced peripheral neuropathy. This is from the same group at Virginia Commonwealth University that Tom Smith was at when they did that first trial, 16 patients with chemotherapy neuropathy. It was an IRB-approved trial. It's associated with relief of pain and sensory motor neuropathies, decreased brief pain inventory interference scales. How much is pain interfering with your enjoyment of life and sleeping and all those sorts of things? There's 7 different interference they have, I think. And the benefit lasted out to 90 days, so 3 months after treatment was done. The 8th trial has Tom Smith there and Marineo from here, 10 patients with post-herpetic neuralgia, and they noted a 95% reduction in pain a month after a 10-day treatment was initiated. Some of these patients, it's not clear how many, were on one of the previous Marineo trials, but they just put them together with some patients that Tom had treated when he was at Virginia Commonwealth University. So the 9th report is actually not a clinical trial. It's some Korean authors who noted 3 patients in a case report sort of thing, but they are very impressed with these 3 patients who had intractable pain related to bone metastasis. And the next one was another one with 3 other Korean authors, also 3 patients, this time post-herpetic neuralgia. This time again, they were impressed. They told you the case story of each of these patients. They seemed to do quite well. Now the 11th trial was a double-blind, placebo-controlled, randomized trial. It was in 14 patients with chemotherapy-induced peripheral neuropathy. The group here who did this trial had little experience. They were from Wisconsin, Toby Campbell. There was no difference between arms, but they had very little experience in doing this, especially for chemotherapy neuropathy. They hadn't done any pilot trials before and all. The sham procedure looked viable, that people didn't know whether they're getting sham or the real thing. They had presented this as an ASCO abstract. There's not been any manuscript. I don't expect there's going to be, just because there's small numbers of patients and the inexperienced, I think. So the 12th report is the Mayo CIPM manuscript that I showed you earlier on. And then the 15th trial is a double-blind, randomized controlled trial published earlier this year in January. 30 patients with low back pain. This was at Virginia Commonwealth University. There were significant decreases in the worst brief pain inventory pain and with the interference scores. They also, with pain sensitivity, where they, over the area where there's pain, they put a little pressure of a needle there, and how much pressure did they have to put before the patient had pain, and it improved in the patients that got the scrambler therapy versus not. And the other thing they had with the heat probe, they put how much heat was it before the patient got pain, and there was improved scores in the patients who got scrambler versus not. And they looked at mRNA expression of 17 pain genes, and there were positive sorts of reports in those genes. I don't understand that quite that well and what it means, but again, this is a randomized placebo-controlled. Giuseppe made some comments about it. It wasn't done exactly the way I would have done it, but the fact that they actually saw the results here in this double-blind, and the patients were most of the patients, somewhere around 75% of the patients in both groups, thought that they were actually getting the real scrambler therapy. What they did for the control, the sham, they put, this was low back pain, so they put the leads about a dermatome above where they should be, and they didn't turn all the juice up as much as you could turn the juice up, but they did something, so they felt something, but didn't turn it up from there. So those are the studies that are out there. It's quite a bit, I think, especially when you see different authors who are seeing the same thing that Marineo first reported. So how does scrambler therapy work? Let's see if I can work this thing to make it work here. So this is something we came up with some time ago. If you have chronic pain, acute pain initially, and then it turns into chronic pain, this red thing going to the brain, and that you put on the scrambler therapy leads, it sends a different set of messages up there, and it gets the brain to feel again that this is no pain. Now, classically, when you treat patients, nothing works for everybody all of the time, and we all know that thing. But when you treat a patient for this, and you put the leads on, and it's something that works, and again, most of the patients it does work for here. You put it on, and it feels some buzzing sort of thing. It's something like TENS. Now, Giuseppe will say it's not TENS, it's not TENS. That works through the gateway theory. If you got touch sensation going in, then the pain can't go in there. And he has a totally different thought process on this. But when you put it on there, the pain goes away in about a minute or so. And Giuseppe used to say, well, ask him if the pain goes away. I tried doing that for a while, but every time I ask that, they say, I can't tell. I have all this buzzing thing and I can't tell. So rather I rephrase it and I say, has this buzzing sensation that you have, has that replaced the pain that you have? And if they say yes, then you got it. Okay? If they say no, I feel the buzzing, but I still feel the pain, then you might not have it in the right area. You may have to change where they put the leads. You don't put it on exactly the same place. You can move it out or above it, so you can change things. And then if you get a successful treatment, while they're on the treatment for 30 minutes, they're comfortable there, and you stop the treatment. And then after the buzzing goes away, their pain is still gone. And then you send them on their way, and then the next day they come in and say, it was good, felt good for 30 minutes, an hour and a half, 2 hours, 15 minutes, a period of time, and then it came back. They're a little bit discouraged by that process. But then that's actually a good sign. If it went away and stayed away for a time, that's good. You did something. So you treat them the next day, and they come back and said it was gone for 3 or 4 hours. And the next day it's 4 or 5 hours. The next day it's 7, 8 hours. And the next day it lasted the night. So it's that training process that goes on is the best way I can explain. So I said before there's no proof that this works. And why do I say that there's no proof that this works? All of the trials have weaknesses. None of them, even the last trial with it was a total of 30 patients, 15 per group. Giuseppe would argue it wasn't given the best way of giving the treatment because they said that they put on 2 leads, right? Get 2 leads for each line, and they put it here and one run right below, and then they turned it on for that. He would argue you put on 1 lead, you turn on, see if that's the right area. If that's not, then you switch it around, you change things around, and then you put on another lead if it doesn't take care of all of the pain process. But it's a relatively small trial. But the fact that it actually brought a benefit is pretty good. But it's, again, that's the best of them, and it's still a pretty small trial. No large placebo-controlled trials. Ideally, with most of the stuff when we have chemotherapy drugs, we want 2 large placebo-controlled trials to demonstrate it. Potential conflicts of interest. Some of the reports involve the inventor, but the fact that other people have looked at it is up there. And there are multiple claims of other therapies where people have said this works and this works and that works, and then eventually you find out it really doesn't work. Am I conflicted? Am I conflicted? Well, potentially I could. As I said, they provided machines and Mayo contract for some money. Gives me an opportunity to write and consult. I've got to know others, including Giuseppe and all those sort of things. Get to come out to Portland, my hometown. So all those things could be things where you could say I'm conflicted. But on the other hand, why not? I actually haven't received the money. It's Mayo, and it actually hasn't received the money there. Opportunity to write. I have plenty of other things to do. I have hundreds of publications. I don't need to do this. I need to more retire than do this sort of thing. Right? And I got plenty of other things that I can do. And I've gotten to know others that know me would argue that will tell you I'm not shy about publishing negative results, and I'm not shy about arguing about people if they say something works, and I say, wait a second, I don't quite believe that, so I'm not afraid of doing that. So conclusions. No proof that Scrambler therapy works, that it provides remarkable benefit, but I'm convinced that it actually does do so. And I do have there is a patient video out there that somebody came, Reuters news agency came and came and talked to one of my patients who had bad chemotherapy neuropathy for a long period of time. Her pain was 12 out of 10, as she says in the video, and she had a remarkable result that actually has lasted for over a year, and she's very, very happy with it. But if you want to see that, to see what the patients actually think, as opposed to myself, put Mayo Clinic Scrambler therapy, and you'll find it there. Thanks for your attention. I'm happy to answer questions if there are any, if this is the right time.
Is it the right time? Yeah.